muscle capillaries in our laboratory, and he determines that the fluid is being filtered out of the capillaries with a net filtration pressure of around 10 millimeters of mercury. So net filtration pressure is given as 10, right? Muscle capillaries in our laboratory, and he determines that the fluid is being filtered out of the capillaries with a net filtration pressure of around 10 millimeters of mercury. So net filtration pressure is given as 10. Right, so when I look over here, the net filtration pressure is 10. He obtains the other following values like this. So capillary hydrostatic pressure is 45, oncotic is 25, interstitial oncotic is 10. You have to determine that which of the following is the interstitial hydrostatic pressure, right? So the way to approach this question is, net filtration pressure is 10. He obtains the other following values like this. So capillary hydrostatic pressure is 45. Yes, good evening. So what we will do is, remember, if this is the representation of my tubule with the Bowman's capsule, this is now, let's say, the tuft of glomerular capillaries. So we have the afferent, we have the glomerular capillaries, and we have the efferent arteriole and peritubular capillaries. So now, yes, audio and video is fine. Everyone kindly let me know. So this is the afferent arteriole, right? This is the glomerular capillaries. And now let's write down all the pressures, right? So the hydrostatic pressure is, which is, remember, PGC. It is trying to filter the plasma out. That is 45, right? So I will just write in front of this. This is a pushing pressure. Then I have the capillary oncotic pressure, which is pi GC, which is trying to pull back the fluid with a pressure of 25, right? 25, that is also given. Interstitial oncotic pressure is given. Interstitial oncotic pressure, right? So over here, in the question, we have given you skeletal muscle capillaries. This you can also change to renal or the glomerular capillaries, right? As I am making the figure of glomerular now. So kindly change it to glomerular capillaries, right? Concept will remain the same. Yes, that's right. And instead of interstitial oncotic pressure, we can write down the Bowman's capsule oncotic pressure, right? Bowman's capsule oncotic pressure. Now let's do the question. Because we are doing renal physiology, that is why I've changed the slide question I have edited. Now as you see this, you will realize that what is happening here is the hydrostatic is 45, oncotic is 25. Bowman's capsule oncotic pressure, which is, let's say, the pi BC, it will also try to pull the plasma out, right? And then we have asked you that which one is the interstitial, or let's say the Bowman's capsule hydrostatic pressure, right? So just a small change because discussion is around renal capillaries, glomerular capillaries. Bowman's capsule hydrostatic pressure I would like to find out, which is PBC, which is, remember, again an opposing pressure. So net filtration pressure is equal to, which two are acting on the same direction, hydrostatic in the glomerular capillaries plus oncotic in the Bowman's, right? Oncotic in the Bowman's minus oncotic in the glomerular minus hydrostatic in Bowman's. Remember, this is what you need to find out for me. Remaining everything is given, right? So let's do it quickly now. This is given as 10. This is given as 45. Oncotic in the Bowman's is given as 10, and oncotic in the glomerular capillaries is given as 25. This I need to find out. So if you do this simple one for me now, 55 minus 25, this is 30. 30 minus 10 would be hydrostatic in Bowman's capsule. So the answer is 10, right? Let's move to the second question now. Increase in which hormone will produce a change in urine osmolarity and urine flow rate as shown in the diagram or figure given below, right? Think about it. So very interesting and good question, because remember, as the levels of this hormone are increasing, right, on the x-axis, what I can see is that the urine flow rate is reducing and the urine osmolarity is increasing. Can you tell me some answer here? Think about it. Urine flow rate is decreasing means I am reabsorbing more and more water, right? And if I am reabsorbing more and more water, the urine flow rate will reduce, but osmolarity of the urine is increasing, means it is becoming highly concentrated. So the answer is none other than ADH, right? So the answer is ADH. Why answer is ADH? Because ADH causes increased water reabsorption, right? ADH causes increased water reabsorption. Because it causes more water reabsorption, this will cause decrease in urine volume and increase in urine osmolarity, right? Yes, aldosterone won't be the answer, because remember, aldosterone is going to increase the sodium and water retention, but the urine osmolarity and urine flow rate is mainly affected by the ADH, right? So aldosterone, if it causes, you know, more water and sodium retention, then after some time, because of increase in extracellular fluid volume, we have the aldosterone escape phenomena, right? So that is the reason aldosterone is not the answer here. ANP is actually going to cause more pressure natriuresis and diuresis, so that is also not the answer. Moving on to question number 3, researchers observe that there is deviation between the actual threshold and predicted threshold of plasma glucose, renal glucose. This deviation is known very well as splay. You can be asked as a short note splay in the exam, what is the reason for the splay? So in the figure given over here, I can see that, you know, the actual Tmax should have been, over here, right? This is the actual one, but I am observing that it is being achieved a little earlier. So why is there a renal splay? Renal splay is the difference between the actual renal threshold of glucose, which is determined as 300 milligram per deciliter in the arterial blood, but in the venous blood, when we see, we find that it is, you know, 180 milligram per deciliter, but that is, remember, the actual. If I convert it to the relative arterial value, I get 200 milligram per deciliter. So the difference is actually of 100 milligram per deciliter difference between the actual renal threshold and the predicted one, right? So predicted is 300, but actual is 200. That is the value of renal threshold. Predicted or calculated, as they say, is 300, but the real world actual value is 200. There is a difference of the 100. Why is this occurring? Because we have done a wrong assumption that all the nephrons, you know, have the same Tmax, that they are homogeneous, but actually they are not homogeneous, they are heterogeneous. That means the answer is nephron heterogeneity. Not all nephrons have the same Tmax. Not all nephrons have the same Tmax. Remember that. So we assume that every one of them is working at 375 milligram per deciliter, but in the real world, some have 300, some have 250, some have 200, some have 220. So the ones with the lesser Tmax will leak the glucose into the urine much earlier, right? Let's move to question number 4. Experimental studies are conducted to study the renal tubular transport proteins. Now, They want to know that we have developed a new drug that specifically and completely inhibits the glucose transport in the proximal tubules. So clearance of this drug will most likely be same as which substance. So very interesting question. Remember, what is happening here is clearance of a solute or the substance is the volume of plasma that is removed or made free of that substance in 1 minute, right? Which is removed or cleared or made free of that substance in 1 minute. Normally, you know that glucose is freely filtered. It is freely filtered and 100% reabsorbed, right? 100% reabsorbed. If I give a drug which inhibits this 100% reabsorption of the glucose, that means the glucose will become like a solute which is only filtered. Which is this solute which is only filtered and neither reabsorbed nor secreted? That is my answer. I think you got the answer. It is none other than inulin, right? PAH will not be the answer because it is secreted. Potassium and sodium again are not the answers because they are not 100% reabsorbed. Only 3 solutes are 100% reabsorbed: glucose, amino acids and the bicarbonates. Glucose and amino acids in the PCT, proximal tubule, bicarbonate 85% in the PCT, another remaining 15% in thick ascending limb and DCT, right? Let's move to question 5. Research experiments are being done to manipulate GFR and renal plasma flow. Which of the following will increase the GFR but no change in filtration fraction? I think we all know what is filtration fraction. Filtration fraction is GFR upon renal plasma flow, right? It is maximum 20% or 16 to 20% fraction of the renal plasma flow that is filtered across the glomerular capillaries into the Bowman's capsule in 1 minute or per unit time. Now remember, if you are having nephrotic syndrome, this will increase the hydrostatic pressure in the Bowman's capsule, which will decrease the GFR. So can't be the answer. It will, eventually be affecting the filtration fraction. But generally they say that this is not the answer because GFR I want to increase, right? And no change in filtration fraction. Nephrotic syndrome will mainly affect the GFR. It will not affect the renal plasma flow much. Ureteric calculus, again stone in the ureter, obstruction to the renal outflow of the plasma. The urine cannot go out from the ureter because there is a stone. Calculus, hydrostat. So this I think I will just correct it. So nephrotic syndrome would be increased loss of proteins. Yes, please see this again. Yeah, and this will cause less oncotic pressure in glomerular capillaries, right? Because I'm having more loss of proteins. Less oncotic pressure in glomerular capillaries. Now this gets interesting. This will increase the GFR, right? This will increase the GFR. But I have also asked you no change in filtration fraction. The problem is nephrotic syndrome does not affect the renal plasma flow, right? So GFR will increase, but filtration fraction, will also increase. It will not be same. Ureteric calculus. Yes, this is the one which is stone in the ureter. Hydrostatic pressure in the Bowman's capsule will increase, thereby decreasing the GFR. Again, not much effect on renal plasma flow. Constriction of the afferent arteriole. If you go back to the first picture which I discussed, if this arteriole is constricted, can you tell me what will happen to the renal plasma flow into glomerular capillaries? This will reduce. So if there is constriction of the afferent arteriole, less renal plasma flow into the glomerular capillaries, resulting in decrease in hydrostatic pressure, resulting in decrease in GFR. Again, remember, less renal plasma flow, GFR is also decreased. The filtration fraction will remain same. but this is not the answer, because I have asked you that filtration fraction should remain same along with increase in GFR. But when you do dilatation of afferent arteriole, this is my answer. Renal plasma flow increases, hydrostatic pressure in glomerular capillary increases, this increases GFR. Within GFR and RPF both are increasing, filtration fraction remains same, right? Same. So the answer is option number D, right? Let's move to question number 6 now. This is a very important question. This can definitely come in your exams. 65-year-old solo traveler, loses all her bag of supplies. That means all her water, food, everything she has lost. And now she is seen wandering without food and water for last 12 hours. So her urine osmolarity is very high, around 970. Where is the maximum water being reabsorbed in this lady? So remember, whether you are overhydrated, I am drinking water all the time, or whether I am totally, completely severely dehydrated. In all these conditions, please remember, maximum water reabsorption occurs in, yes, what is the answer? PCT. How much? 60 to 70%. Please remember, this is famously called as obligatory water reabsorption. So whether you are overhydrated or dehydrated, maximum in the PCT. Now questions, student says, sir, can the answer be collecting duct? The answer is yes. If I change the stem of the question, that I ask you, instead of various maximum water reabsorption, where is the maximum water reabsorption occurring in this lady? But I change the question, I ask you, in this lady, a hormone is released from the posterior pituitary. What is the primary site of action of this hormone? If I ask you like that, then please remember, in this lady, there will be excessive release of ADH or vasopressin, and the primary site of action of vasopressin is collecting duct, right? So if I ask you a question like this, then the answer is ADH, but please remember that will only be the answer if I ask you the primary site of action of ADH, right? So whether the ADH is there or not, maximum water is still reabsorbed where? Yes, PCT. In the collecting duct, nearly 13 to 15% we say, right? 13 to 15%. Moving on to question number 7 now. Plasma glucose is given as 400 milligram per deciliter. GFR is 125. Tmax is 375. What is the excretion rate of glucose? So we say, net excretion rate of glucose. Remember, glucose is not secreted. So if I want to find out net excretion rate of glucose, I need to know the net filtration rate minus the tubular reabsorption rate of glucose, right? Now over here, I want to find out excretion. I need to calculate filtration rate. How will I do that? I need your GFR and the plasma concentration of glucose. Are they given to me? The answer is yes. This is 125 ml per minute into 400 milligram per deciliter, which can be written as 100 ml. You solve this for me. You will easily tell me the answer is 500 milligram per minute. This is the net filtration rate of glucose. But can you tell me what is the reabsorption rate given to us? The reabsorption rate given to us in the question is 375 milligram per minute, which is, remember, the Tmax, maximum rate of reabsorption of glucose. So 500 minus 375, the answer is none other than 125, right? This takes care of this one as well. 125 is the answer. Moving on to question number 8. Which curve describes the inulin profile along the nephron? These are slightly difficult questions. If you look at the y-axis, you are seeing the percentage of filtered load remaining, then I'm showing you different solutes, although I have asked you, inulin, and in the next one glucose, but I will tell you the other answers as well, right? So as I am moving from the, please look over the x-axis, Bowman space through proximal tubule to distal tubule to urine, right? What do I want to know? That the concentration of the, or the remaining amount of the solute, how much percentage is remaining, right, in the Bowman's capsule, proximal tubule, distal tubule, or urine. So let's see the first one. A is something, which is getting 100% reabsorbed in the proximal tubule. So you see in the proximal tubule I am having the 0% of the remaining filtered load. That means A is something which has been 100% reabsorbed. So what could be the options for the next time 100% reabsorbed are glucose, amino acids, right? Now in the PCT, if the concentration in the proximal tubule is 0, that means 100% has been reabsorbed. B is something which is still present at low concentrations in the proximal tubule, this much, right? That is still present. That means 100% of B has not been reabsorbed, but lot of high percentage has been reabsorbed. So what could be B? B is none other than bicarbonates. Remember, it is 85% reabsorbed in the PCT. That means even after proximal tubule, I have some amount of bicarb. And as I am approaching after distal tubule, 100% has been reabsorbed. Now using the same logic, C is something whose fraction of the filtered load remaining remains constant. So what is C? Think about it. C is something which is neither reabsorbed nor secreted. So C's percentage of the filtered load remaining in the tubule, then distal tubule, and urine will always remain constant. So C is the answer over here because that is inulin. And finally, what could be D? D is anything which in proximal tubule becomes more than in the Bowman space. That means D is the one which has been secreted. And generally, who gets secreted in the proximal tubule? The answer is PAH. So in the proximal tubule, we have the secretion of para-aminohippuric acid. So D is PAH, C is inulin, right? So now let's go for the answer. C is inulin over here. And the next one, which is the glucose, I think you all have understood. Because glucose is touching 0 in the proximal tubule, it has to be none other than A, right? Let's move to question number 10 now. Shown below is the graph of plasma concentration and clearance. Which of the following represents pH? Again, a different type of clearance curve. One out of these will definitely come in exam. These are very hot favorite questions for the examiners. So, again, you are seeing that clearance is constant of the C. C is something whose clearance always remains same, constant. That means it is none other than inulin. But remember, inulin is neither reabsorbed nor secreted. So anything which is below the inulin line, which is D over here, is the solute which is reabsorbed. Anything which is above the inulin line are the solutes which are secreted. Can you now tell me what could be D and what could be A and B, right? So para-aminohippuric acid is definitely secreted, we know that, and its secretion is carrier mediated. But please remember, A is having much more secretion than B. That means A is secreted to a very high extent, but B is only partly secreted. So A is the answer for my question here. A is the pH. B, remember, is the creatinine, because creatinine is partly secreted. C already I have told you is inulin, and D over here could be my glucose, right? Glucose. Let's move to question 11. The diagram depicts renal handling of which of the following substances? Suppose you don't know a thing out of it, then doesn't matter. Please see over here, PTH, parathyroid hormone. This should give you some answer hint, because remember, PTH increases the reabsorption of which common ion in this DCT? This is, remember, DCT. What is the answer? So answer is none other than calcium. So very important one, parathyroid hormone, remember, increases the calcium reabsorption in the DCT, but it decreases the phosphate reabsorption in PCT. You have to know this, very important. Question number 12. Which of the following segments of the nephron is freely permeable to urea? Remember, urea handling by the kidney we have done in detail, and you just need to know that the segment which is freely permeable to urea, the question is a tricky one. A lot of students say collecting duct, but actually the best answer is IMCD, inner medullary collecting duct. Inner medullary collecting duct. This is freely permeable to urea, and remember, urea is reabsorbed in the PCT nearly 52%, right? But inner medullary collecting duct is freely permeable to urea, right? So recycling of urea occurs in the inner medullary collecting duct, right? Very important question. Final excretion of urea is only 20 to 40%, right? 20 to 40%. Fine. Let's move to question 13. Maximum calcium reabsorption occurs in which part of the nephron? So remember, calcium mimics the sodium. So calcium answer is PCT. 65% to 67% is in PCT. Thick ascending limb around 25%. DCT around 7%. And less than 1% calcium is excreted, right? Less than 1%. Remember one additional question here. If they ask you which is the only ion which is maximally reabsorbed in thick ascending limb of loop of Henle, please remember this tricky one. Magnesium is having maximum reabsorption in thick ascending limb of loop of Henle. Remember that. Around 65% of magnesium, 60 to 70, is reabsorbed in actually thick ascending limb of loop of Henle, right? Very important one. Then moving to question 14, the following laboratory values were obtained in a 58-year-old man. Urine flow rate is given, serum creatinine is given, urine creatinine is given, plasma potassium, urine potassium. You have to calculate what is his approximate GFR, assuming that he collected all his urine in the 24-hour period. Remember, normally we say the gold standard for the GFR measurement is inulin clearance, but the clinicians prefer to use creatinine clearance. The reason is creatinine is an endogenous product of your muscle metabolism, but the inulin is exogenous, which has to be given by a bolus dose followed by continuous intravenous infusion, right? So clinicians prefer creatinine. That is why I've given you creatinine here. You just have to use a simple formula for me. Clearance of creatinine or any solute per se is equal to urinary concentration of creatinine, I am writing in short, into V, urine flow rate, upon P, which is plasma concentration of creatinine, right? Let's do the answer. So urine flow rate is given as 3 ml per minute. Creatinine concentration is given as 3 milligram per 100 ml into so first let us write down the urinary creatinine. This is given as 50 milligram per 100 ml Then urine flow rate is given as 3 ml per minute, and plasma concentration of creatinine is given as, or serum creatinine, same thing, 3 milligram per 100 ml. You solve this for me, very easy calculation. You will get the answer 50 ml per minute, right? What is the answer? 50 ml per minute. A lot of students say, why have you given potassium? Maybe just to trouble you, right? Waste your time, confuse you. Which of the following has the maximum reabsorption in the PCT? One liner, but a previous question of the exam as well. Remember, very interesting question. So sodium is around 60 to 70%. Potassium again is around the same value. Calcium is around 67. But bicarbonate is the answer, because approximately 85% of the bicarb is reabsorbed in PCT, right? So the answer is not sodium. That is why I have given you this question here, right? 85% of the bicarbonate is reabsorbed in PCT, right? Moving to question 16, relaxation of the mesangial cells of the kidney is brought about by. Remember, if you could recap for me, mesangial cells relaxation is a very, very important concept. If this is a tubule, and remember, these are my glomerular capillary representation, afferent arteriole, glomerular capillary, and efferent arteriole. Remember, we have the cells known as GMCs, glomerular mesangial cells, right? These are normally present like this in between the glomerular capillaries. If you do their contraction, remember, they encroach the glomerular capillary lumen. If they are encroaching the lumen, can you tell me, if I do their contraction, I encroach the glomerular capillary lumen, the capillaries become kinking. The capillaries show kinking. Kinking means twisting. So the agents which cause increased contraction of the glomerular mesangial cells will cause decrease in surface area of the glomerular capillaries by causing kinking of glomerular capillaries. Kinking means twisting. Remember, you are washing your car with a rubber pipe. Suddenly your brother comes or sister comes, takes the pipe and just twist it 10-20 times. What is going to happen? 5-10 times, 20 times, 30 times I am doing this. Lot of kinking, twisting. This causes decrease in surface area of the capillary, resulting in fall in GFR. But here I am asking you the opposite. Lot of agents can cause decrease, GFR by causing kinking or increased contraction of glomerular mesangial cells. We have the huge list: angiotensin 2, endothelins, norepinephrine, epinephrine, vascular endothelial growth factors, prostaglandin F2 alpha, leukotrienes. But please remember the other one, the ones which cause relaxation of the glomerular mesangial cells. If I do relaxation, remember, these glomerular mesangial cells, they move away. If they move away, then naturally this will give more area for the plasma to filter. So this causes increase in surface area of the glomerular capillaries, thereby causing increase in GFR. Which are the agents which do that? We have a very simple mnemonic. Papa has CAD. Whose Papa? Naturally not mine, and maybe someone else's Papa, right? So Papa has coronary artery disease, PCAD, coronary artery disease, right? Coronary artery disease. But actually, coming back to the mnemonic, PCAD stands for, these are the only 4 agents which cause relaxation: prostaglandin E2, cyclic AMP, ANP, atrial natriuretic peptide, and dopamine, right? DA is dopamine. So please remember, These are the only 4 agents which cause relaxation, thereby increasing GFR. So the answer is none other than cyclic AMP here, right? Let's move to next one. GFR is increased when? This is very important. This is a one-liner but can definitely come in your exams. GFR is increased when? Remember, if I am increasing the plasma oncotic pressure, think about it. I increase the oncotic pressure in glomerular capillaries, the GFR will decrease. The glomerular hydrostatic pressure is decreased, the GFR will decrease. Tubular hydrostatic pressure is increased. When does that happen? I have already told you. Yes, obstruction to the outflow of urine, ureteric stone, ureteric calculus, GFR decreases. So naturally the only correct answer is increase in renal blood flow, because increased renal blood flow or renal plasma flow will cause increase in hydrostatic pressure in glomerular capillary, which will cause increased GFR. Fine. Let's move to 18. Maximum, this is a tough one, but you have to know this fact. Maximum sodium reabsorption in PCT occurs through which transporter? Remember, in proximal convoluted tubule, we have various kinds of symporters, sodium, glucose, co-transporter. Major one is SGLT2. Then we have, the basolateral pump transporter, sodium potassium ATPase. We have sodium amino acid. We have sodium inorganic phosphate. We have sodium lactate. But please understand, none of them are contributing maximum. The maximum sodium is by sodium hydrogen exchanger known as NHE, which contributes nearly 50%. Please remember that. The sodium glucose co-transport contributes only 5%, only 5%, and the rest reabsorption of sodium is occurring via other ones such as sodium amino acid co-transporter, sodium lactates co-transporter, or sodium inorganic phosphate co-transporter, right? So NHE, remember, is the major one. Moving to question number 19. Single most important factor in generation of renal medullary hyperosmolarity is. Please remember, we have two types of countercurrent systems. I have given you one more question. Countercurrent multiplier is the countercurrent system which helps in generation of hyperosmolar medulla. Vasa rectae is the countercurrent exchanger which maintains the medulla, hyperosmolar medulla. In generation of hyperosmolar medulla, we have role of two things. We have the role of NKCC, which is sodium potassium 2-chloride co-transporter. So reabsorption of sodium along with potassium and chloride in thick ascending limb of loop of Henle. But please remember, the answer is actually urea, because urea is the single most important factor. Urea alone contributes 50 to 60%. Please remember this, very important. Moving to question 20. Tubuloglomerular feedback is mediated by, again, important topic, autoregulation of GFR. Remember the three mechanisms as done in the video: myogenic mechanism in the vascular smooth muscle, tubuloglomerular feedback in the macula densa, and glomerulotubular balance in the PCT, right? Over here, tubuloglomerular feedback is mediated by sensing of the sodium chloride both in the macula densa. This is the best answer. Although remember, macula densa is more sensitive for chloride, surprisingly, more than sodium, right? So surprising for you, right? So more sensitive for chloride, because we believe that it should be sensitive for sodium, but it is the other way around. It is actually more sensitive for chloride, right? This might be asked. It's a tough question, right? And macula densa is located where? Again, remember there is a slight controversy. It is located at the junction of the distal part of the thick ascending limb of loop of Henle with the early DCT. DCT is considered as the better answer, although in Genong it is given as TAL, right? Moving on to 21. Several hormones regulate the tubular reabsorption of water and electrolytes at different sites in the nephron. Which of the following combination is correct? This is a very important question. Please remember, angiotensin is not in distal tubule. Angiotensin main site is in PCT and thick ascending limb of loop of Henle. Aldosterone is the correct answer. It acts in the late TCT and collecting duct, but naturally the major action is in the principal cells of the collecting duct. ADH never acts in proximal tubule. This is wrong. ADH's main site of action is, yes, collecting duct. ANP again do not act in loop of Henle. ANP's main action is, yes, where does the ANP act? Collecting duct again, especially in the medullary collecting duct, MCD we say. Right, medullary collecting duct. Moving on to question number 22. What is the principal site of acidification of the urine? Very interesting question. Where does the urine get acidified mainly? So remember two different questions. If I ask you where is the maximum acid secretion, in the PCT 4200 millimole per day of acid is secreted. So remember always, maximum acid secretion occurs in the PCT, but despite having so much acid, the PCT hydrogen ion is not able to acidify the urine because of the bicarbonate which does byhandling of this H+, right? Please see this video from the recorded lectures. The principal site of acidification of the urine is actually, the answer is collecting duct. And over here, although there is only 80 millimoles per day of acid is secreted, but please remember this secretion occurs mainly in I cells. I stands for intercalated. Remember, I recall it like this for the exam. I has an I and acid also has an I, right? So intercalated cells are my cells in the collecting duct which do maximum acidification of the urine, right? Why acidification maximally in collecting duct? Because remember there is no bicarbonate here, so no one to byhandle, right? So suppose there is one intern senior of yours in your college and hostel who is bothering you, troubling you. So initial and first year he keeps on troubling you, does not let you do anything, right? But after 1 year his internship is finished, he goes to do post graduation out of Delhi or maybe some other place in AIMS or other college, JIPMER. So now nobody is bothering you, you are all alone, right? So you can do whatever you want. Similarly, example as I told you, analogy, H+, PCT can't work, bicarbonate is there. By the time it reaches collecting duct, in the collecting duct there is no bicarbonate. Why no bicarbonate? 100% of the bicarbonate has been reabsorbed. Moving to 23. All except the following are components of countercurrent multiplier system. I think I already told you the answer earlier, that these three are components of the multiplier system, but vasa rectae is not the component of multiplier because multiplier generates the hyperosmolar medulla. Vasa rectae is the component of countercurrent exchanger. It maintains the hyperosmolar medulla. It maintains the hyperosmolar medulla, right? Remember that. Moving to 24. Volume of the bladder is not increasing with increase in pressure. Why? Very interesting question. Remember, Poiseuille-Hagen law is not the answer. Poiseuille-Hagen law is simply R is equal to 8 eta L upon pi R4. We have studied that in cardiovascular physiology. This is not the answer. Bernoulli's law simply states that sum of potential energy plus kinetic energy plus pressure energy is always constant. This is also not the answer, right? Potential energy plus kinetic energy plus pressure energy is always same, constant. Energy can neither be created nor destroyed. Fick's law of diffusion we have studied in the chapter number 1. This was, if you could recall for me, Fick's law is J is equal to, yes, minus D into A into delta C upon delta X. So the answer is actually Laplace law. And what is this figure shown over here to you all? This is famously known as cystometrogram. Cysto means bladder, metro means measuring, gram means graphical recording of the pressure changes in the bladder along with filling of the urine in the bladder. Let me zoom the picture, please have a look. In phase 1A part of the figure, as you are drinking the water, the bladder is getting filled with urine. The intravesical pressure means pressure inside the bladder increases to 10 centimeter water. But then in phase 1B, you are drinking water, but it is a straight line, your pressure is not increasing. Why is that so? There comes the Laplace law, which states phase 2, remember, is famously known as flat part of the curve. Flat part of the curve. Why? Laplace law states that P is equal to 2T upon R, where P over here is intravesical pressure. Intravesical pressure. R is the radius, like always, and T is the tension in the bladder. Now, as you start drinking the water, initially the pressure is rising in phase 1A, but in phase 1B, what I observe is that, as the person is drinking the water, the bladder will start getting stretched. The smooth muscle of the bladder shows a property of plasticity. So as you drink water, the tension increases, but radius also increases. So will the pressure increase? The answer is no. Pressure remains same. This is known as a very good application of Laplace law. Remember that Laplace law is mainly taught in respiratory physiology, but it has application in renal as well as cardiovascular, right? Left ventricular hypertrophy in case of untreated hypertension is again an application of Laplace law. Then in phase 2, I observed that suddenly the pressure rises to a very high value. Why is the pressure rising to a very high value? Because remember, the stretching of the smooth muscle of the bladder has a maximum stretching capacity. After 400 ml, you cannot, hold the urine. So maximum volume of urine which you can hold in the bladder, beyond which there is huge rise in pressure, is 400 ml. And the first urge to pass urine is felt in between 100 to 200 ml. Additional 2 questions, remember that. Finally, moving to the last one. The graph given below, this is a picture taken from standard book. The graph given below depicts filterability of Dextran. Dextran is a large polysaccharide molecule, 1 representing complete filtration, 0 representing no filtration. Which of the following are A, B and C respectively? Please look at the picture now. They are showing you on the x-axis effective molecular radius, on the y-axis relative filterability. The radius is given in angstrom 10 raised to the power minus 10, right? That we know. How will I approach this question? Remember, suppose I take the standard size of the particle as 26 angstrom, right? Now I have the first one, which is A, which is showing me roughly this much filterability. That means around, let's say 0.1, right? Seemingly little more than 0.1, I am writing 0.1. B are some charged particles which are of the same size as A, but showing much more filterability, right? That means we are talking about the charges here. Then C are the third type of charged particles which are showing me the maximum filterability. Now can you tell me glomerular basement membrane is negatively charged. So out of A, B and C, if the size is same, which particles will have maximum filterability? So the answer is C should be positively charged. That means C are none other than cationic. B has to be none other than neutral. And A has to be none other than anionic. So what is the answer? A is polyanionic, B is neutral, C is polycationic, right? So very important one. Remember, how did I do that? Simply take the same particle size and then see the positively charged will be attracted by the negative basement membrane, the negative will be repelled, and the neutral will be in between, right? So this takes care of the discussion of the renal physiology. So we have one topic left, which I'll be doing in next time, that is endocrine and reproductive physiology, right? So take care all of you, and best of luck for the upcoming exams, right? God bless you all.